Bone marrow depression. Anemia. Risk for infection. Risk for bleeding. I went through that. The rash, blood dichrasis, which is basically abnormally low blood levels. We already said we're going to affect the bone marrow, right? Affecting the bone marrow, what are we affecting? We're affecting blood cells.
Yes.
Anemia, well, we already covered loss of blood cells, right? It's all kind of in that same thing. Nystagmus, that's this rapid eye movement. Not really a life-concerning issue. Respiratory depression, hypertension, pinpoint pupils, coma, and death. All signs of excessive what? CNS depression. So it causes CNS depression. We gave them too high of a dose. We're going to cause them to basically lead to neurological failure and then death. Okay. So looking through this, everything is pretty much covered under what? Those generalized adverse effects, right? They all kind of blend together. Nothing new we didn't cover already. And then down here it's kind of hard to see, but it says transgenic pregnancy category D. Majority of your antiepileptics are going to be category D. Makes sense, right? One, they're CNS depressants. They affect bone growth. Hepatic dysfunction, your liver dysfunction. So ALT and AST, decreased metabolism. So if you're growing a little baby human, take him that decreases bone marrow, decreases vitamin D deficiency, decreases liver function, decreases your blood counts. Does that seem conducive to healthy baby growth? Not really, right? So if someone has extreme epilepsy, you kind of have to wager, do I want to have a kid? Do I want to maybe have a seizure, right? Because it's kind of this guessing game here. If my epilepsy's not that bad, I can risk it. But if I have a seizure, I could lose the child. So it's one of those things you really have to be careful for women when it comes to epilepsy and childbirth. All right. Phenytonin, Dilantin. Be good for all seizure types except for alpha seizures. IV route for status epilepticus. Anyone want to guess what status epilepticus stands for?
Actively seizure.
Actively having a seizure, right? They're actually having a seizure. So if someone's actively seizing, we want to give them the fastest route of administration we can, right? IV. I can be like, okay, let's just crush the pills, put them in your mouth, and just slide them down while you're seizing. Good luck. It'll have an effect in 2 hours. Hope you make it. Okay. So note, we can give someone who's actively seizing. It's not the best drug to give someone who's actively seizing. If you ever know anything about epilepsy, you can give multiple medications IV for someone who's actively seizing. Okay? But there's one drug class that's good and effective for everyone that's seizing. That's going to be our one drug class of choice. We'll get there. Okay? We can give Dilantin. It's not the best one. If I were to ask you what the best one is, you're not going to tell me Dilantin. Okay? Exaggerated wink before the classroom. All right. Next thing. Highly protein bound. So, what do we want to do with this?
Give it an hour before meals or 3 hours after?
Yes. Hour before meals, 2 to 3 hours afterwards. Because the lantern is going to bind to any protein and become inert. Same time every day.
I had a question. This says first line therapy. It's not the first thing we give for epilepticus though, right?
No.
Okay.
This is kind of the good standard for treatment,
Okay.
not for recovery.
Okay.
Need to adjust level for patients with hypoalbuminemia. Who remembers what albumin is?
For your liver function.
It's a sign of liver function because your liver makes it. Okay? So your liver makes your albumin. I was getting there? Good job. It's a good sign of your liver function. Okay? What actually is albumin? It's in the bloodstream. Is it a lipid, a protein, or a carbohydrate? It's a protein. Okay? Albumin is a protein made by your liver. Proteins have something called oncotic pressure. Okay? So what is oncotic pressure? It is the pressure protein exerts on the solution it's in, right? Remember, things go from a high gradient to a low gradient, right? So things are going to diffuse where there's, well, something, oh, looks like it goes from a low to a high, sorry. It wants to get diluted, right? So in our bloodstream, we have a lot of albumin. So it's going to have oncotic pressure. It's going to help pull fluid into the bloodstream, right? So it's going to help us maintain what? Blood volume and blood pressure. Okay? Without this, what's going to happen to that fluid in the body? Without the albumin kind of keeping it in the bloodstream, it's going to like third space out and diffuse out into the body. Has anyone seen someone with liver failure before? I've seen a Stay Puft Marshmallow Man from Ghostbusters. He's all like a Michelin Man. People need to watch a lot of movies. Okay, classic American television. Anyways, they blow it out. They get extreme edema. The liver has failed. The liver is not making the albumin. There's no oncotic pressure. They get to the point where basically they'll start to like basically just weep out fluid from their skin. Whose phone keeps beeping? You are really important, whoever you are. I'm a little jealous because my phone is not buzzing my pants at all. And no one cares I'm here. And everyone else keeps blowing up all the time. All right. So albumin, oncotic pressure helps maintain our blood volume. Okay. This is protein bound. Albumin's a protein. Hypoalbuminemia is low albumin. So if we have a patient with hypoalbuminemia, what we're going to do to our dose? Increase it or decrease it?
Decrease. Decrease.
I heard one decrease, I got a lot of increase. Who says increase and why?
Because it's already low. So the hypo shows that it is low. So we need to boost it up.
Okay. This isn't protein, right? It's affected by the protein. So, we have a lot of protein in the blood. We're going to do what with this dose? Increase it or decrease it? Because we got to counteract the protein binding, right? You want to increase the dose, right? Because we know a certain amount of the med is going to get bound to the protein, right, and come in there. So if the protein is low, there's less protein binding, right? So there's more of the dose active exert in the bloodstream. So we want to decrease the dose with this hypoalbuminemia because we know average person should have so much protein in their bloodstream, right? And because of that, we know this is going to bind to it, and so we have to give them a certain dose to counteract that binding. If the protein gets too low, the binding is going to drop. Meaning there's more available, we should decrease the dose so it doesn't get toxic. Our range is 10 to 20. That's kind of low, right? It's not a wide range. If our liver all of a sudden kicks out and dies, we're going to have issues. Okay, does that make sense? Less protein, decrease the dose because we're getting less of the protein binding. When it comes to meals in the regular dose, 1 hour before, 2 to 3 hours afterwards. Why do we give it 1 hour before and then wait 2 to 3 hours after we've eaten?
So it won't bind the proteins in the food?
Why?
Digestion, for digestion to take place.
Okay. Yeah. Remember when your stomach's empty, you digest things quicker, right? If you have an empty stomach, you take your Dilantin, it's going to be absorbed quicker. It's going to be breaking through the stomach, pass through quicker than normally would. I went and had sloppy joes in my stomach and sit there a while, kind of churn around, this and that, yada yada. It's going to take time for my stomach to process it through. So if we ate a meal, we want to give it time for that food to process through before we give the medication. Okay? All right. Let's talk about the side effects. Gingival hyperplasia. Anyone has to guess what that is?
The gums go up over the teeth.
Yes. The gums get hypergrowth. Plasia is growth. So your gums and teeth will overgrow your teeth. So you need frequent dental exams. Abdominal discomfort, constipation, CNS depression, right? You're going to slow things down. Ataxia and restlessness, rapid eye movement, confusion, slurred speech, all signs of CNS depression. Okay. Anemia, low white blood cell count, vitamin D and calcium deficiencies, both those together are your osteoporosis, bone marrow depression, right? So none of those are new to us. All we have is gingival hyperplasia is the only new adverse effect we have, right? Other than this, all the generalized stuff we already covered. Plus, we now have hypoglycemia, decreased blood sugar. Blood sugar is less than 70. Okay. Less common, hepatic damage. Why is that important? We want to monitor liver function with this medication. One, make sure liver still works, right? Make sure it's not failing. But what else? Where did the albumin come from?
The blood?
Albumin came from the liver, right?
Mm-hmm.
So if we start getting liver damage, we're going to make less albumin, which is going to make the drug more toxic. It's going to kill the liver quicker in this vicious cycle. Okay? Stevens-Johnson's syndrome, which is that rash, right? Paradoxical seizures. So we're causing CNS depression, and we're not going to get a seizure from CNS depression. Which sounds odd. Usually it's CNS excitability that causes the seizure, right? But in this case, because we suppress the CNS so much, the brain freaks out and then has a seizure. That's why it's paradoxical. It shouldn't happen, but it does. Cognitive impairment. This arrhythmia is hypotension. This arrhythmia comes from lack of heart control, right? Heart slows down. Heart, electrical conduction through the heart slows down. Heart freaks out. Rapid beats. Hypotension. Again, CNS depression. Okay. So looking at This one, what new things we have to cover? We have to cover gingival hyperplasia, hypoglycemia, and that's pretty much it, right? Everything else can be classified as a general antiepileptic adverse effect, right? The only new ones we truly had that are kind of like, whoop, pops out at you, is gingival hyperplasia and hypoglycemia. Note the tranogenic effect of a cleft palate and then heart defects. Cleft palates where the upper teeth kind of grow up and form like in your nose and is an issue. My cousin had it. He was adopted. But it was like pretty pronounced. We had to restructure his mouth and all of his teeth. Makes sense because we're going to cause gingival hyperplasia. We're affecting the mouth, right? In the fetus that's not even fully functioned, it's going to affect it differently and affect that whole gingival growth. It can lead to heart problems, heart defects. Okay? When I said all antiepileptics, they're only going to be an issue for pregnancy. Next, let's talk about benzos. Everyone's favorite drug class. You got a problem? These can fix it.
Give me some Valium.
Exactly. It doesn't matter what your problem is, this is going to fix it. You're not going to create a problem anymore. Benzos work great for a lot of different things. They're also highly addictive. So there's an opioid problem, there's also a benzo problem. Okay? Benzos all end in ham or lamb. These are lamb pants. Remains off with right there. Okay? So, remember I said last week, a good way to remember medications is knowing the prefix or the suffix. This is kind of where we get that, right? We know if it's a lamb or ham, it's a benzo. Okay? Benzodiazepine. It's going to work great. Typically used for status epilepticus. Notice how it's all in bold print. Was Phenytoin in bold print? Nope. This one is. So if I were to ask you a question, hypothetically on an exam or a quiz, I don't know, maybe both, we'll see. And it says, what's the best drug to give someone who's actively seizing for status epilepticus? What would you tell me? You would tell me, because you're a smart class of students, a benzodiazepine, right? Because generally speaking, benzos work great on everyone for CNS depression. Some meds work better than others. Benzos work pretty much great on everyone. If someone's actively seizing, that's what it gives you to be lorazepam, Ativan. The only withdrawal can kill you, alcohol withdrawal. What we do, we treat it with benzos, Ativan. Ativan is for the severe. We also can give Librium, another weaker benzo, oral route. But if they have issues, what you can see was that withdrawal scale for alcohol abuse, we treat it with benzos. Someone withdraws from alcohol, they get hallucinations, anxiety, tremors, their heart goes back, they have seizures. This is going to treat all of that. It's a one-stop shop of great nursing care in one injection. So what are the adverse effects? One, risk for abuse, right? You want to be aware of that. The main one is going to be respiratory depression. Respiratory rate less than 12. Some overdoses, can we give them Narcan?
I would, but
Is this an opioid?
No.
No. Narcan only works for opioids. So if we're in EMS, we go to the scene, someone's down, we assume overdose, we're going to assume it's probably an opioid, right? So we'll probably do Narcan first. If we do Narcan, nothing happens. Might give more, but we're going to think, okay, Narcan didn't do anything. Do we know it's an opioid overdose? It could be a benzo overdose. In that case, we give flumazenil or romazicon. This will reverse benzodiazepine, right? Respiratory rate is now 8. We want to reverse it, we gave too much. It also has anterior grade amnesia. Basically, short-term memory loss. We're in the medical field, right? We do procedures that patients probably don't want to remember. Colonoscopy. Anyone had one?
I had an endo.
I remember crap for days. I would not go down. He gave me more and more Versed until I was just saying highly inappropriate things to everyone in the room, and then then we're never done. Okay. So basically what's happening is I don't remember anything because the anterograde amnesia kicked in gray. I lost like two days of my life. I don't know what I did. I assume it was me. I probably sat on my couch and did nothing. Let's be real. Or I robbed a bank. Who knows? But anterograde amnesia happens pretty much automatically. I wasn't really sedated. I was a little bit sedated because I was on cloud 9 apparently.
You
But I
didn't
don't
drive
remember
home,
anything.
did you?
So for certain procedures, it's a good thing. If someone is intubated, going for an EGD, a bronchoscopy, something invasive, we can give this. Okay, give a benzo for sedation so they don't remember what happened. You get the sedative effect, and they forget that you had a giant camera shoved up your butt. It's a good thing. All right, Tegretol. Carbamazepine can treat generalized seizures, but can cause absence seizures. Less sedating than other antiepileptics. So far, it sounds like a good drug to give, right? Treats all seizures, less sedating, can cause absence seizures. Okay. But very narrow therapeutic range. It has a lot of drug-to-drug interactions, which is not good. It can become toxic very quickly. Let's look at our issues. We have dizziness, somnolence, ataxia, itching rash, constipation. Generalized CNS depression, right? Hyponatremia. What should your sun levels be above?
135?
135, right? 135 to 145. So we're at risk for hyponatremia. So the low sodium count, which is bad. Sodium drops too low, brain function pretty much ceases to exist because your brain can't function properly. Okay? Liver failure, ALT, AST. Even Johnson deficiency. Extreme risk for bone marrow suppression. Can we survive without any bone marrow?
No.
Not really, right? It'd be really hard. It'd be hard for us to do much anything without bone marrow. We have literally no blood. Okay, so that's where the issue is. So it's a huge risk for bone marrow suppression. It's hereditary because of why? Well, the bone marrow suppression. Fetus has to grow bones and blood and marrow. It can't. It's not viable. All right. Depakote, valproate. All these people know those Depakote sprinkles. A little capsule, you pop it open, put in some pudding, spoon it to your patient. Highly protein bound. Okay, so again, Give it 1 hour before meals, 2 or 3 hours after meals. Alright? Narrow therapeutic range again. Let's go through some of our side effects. Nausea, vomiting, vision change, alopecia, hair loss, okay. Nausea, weakness, ataxia, tremors. So this right here is kind of your, still kind of your CNS depression, right? We're kind of just slowing things down. Thrombocytopenia. Who wants to hazard a guess or check Google? What is thrombocytopenia? It has to do with one of the things in your blood. What are we affecting?
Your platelets count
What about our platelet count?
is too low.
You get the dangerously low, right? Platelets should be 150 to 400. So they're now going to be drastically low. Platelets are low, what are you at risk for?
Not being able to clot.
Yeah, risk for bleeding, right? Huge risk for bleeding. Elevation in LFTs. Liver function tests. We didn't go through liver function, but the liver does something else important for coagulation. What does the liver do in regards to their coagulation? It makes something. 2 words. First word's a C, second word's an F. What is important with coagulation that the liver makes? Anyone want to hazard a guess? It doesn't make blood, but the bone marrow makes the blood. It makes something that goes in the blood, goes in the plasma. What is going to make the clotting factors? Okay. Clotting factors work in 2 different cascades. And then they allow clots to form with platelets. So, one, we're affecting the liver, right? Decreased clotting factors, decreased platelets, recipe for huge risk for bleeding, right? Patients are going to have bleeding issues. Here we see the hepatic damage, Stevens-Johnson syndrome, pancreatitis, infection of your pancreas. Generally pretty likely if not caught soon enough. And then the black box warning is going to get a hepatic failure, right? So we want to monitor our liver function. Here's some of our newer medications, okay? When we're talking about, when we generally have newer generations of medications, generally one thing happens. Generally they get safer, right? It might not be as effective, but they're generally safer. We have Lamictal, Keppra, Neurontin, Lyrica, so gabapentin here. Look at our adverse effects. CNS suppression, CNS suppression, CNS suppression, CNS suppression, and some weight gain here, and Stevens-Johnson. So what they'll do, they're all anti-epileptics. They're going to lead to CNS suppression, right? Makes sense. And this one has the Stevens-Johnson syndrome. So our new ones, and then here's the other slide. Dopamax, Vimpat, and then Triliptat. Hyponatremia, bone marrow suppression, ammonia levels, liver function, calcium, bone function, hypotension, liver disease. So all of these ones all have the side effects of generalized adverse effects for epileptic medications. Okay, there's nothing new or exciting we're missing with these. So there's 7 meds. All I have to do is remember, it'll be in the question, patients taking blank for epilepsy. You go, okay, it's one of the newer ones. It's going to have the generalized adverse effects. Okay? So do you need to study all 7 of these medications individually? No. just know that they're anti-epileptics and have the generalized problems. Okay? Drug interactions, oral contraceptives, warfarin